Hi, I'm Violeta Popov. I'm a gastroenterologist at the Manhattan VA and NYU Langone Medical Center.
Hi, and I'm Dr. Stephen Chang, I'm also from NYU Lincoln Medical Center.
We are here to present our study, Endoscopic Balloon Dilation for treatment of sleeve gastrectomy stenosis, a systematic review and meta-analysis. On behalf of the team of authors, which also includes Dr. Christopher Thompson from Brigham and Women's Hospital. We would like to thank the editors of Gastrointestinal Endoscopy for the opportunity to present our study.
So a little bit of background about why we chose to pursue this study. So we all know sleeve gastrectomy is an increasingly popular bariatric surgery with relatively low adverse event rates. And one such adverse event is sleeve gastrectomy stenosis, which commonly occurs due to the narrowing of the lumen or torsional scarring due to the alignment of the staples along the greater curvature of the stomach. But unlike stenosis that are found in room-wide gastric bypass, which we typically can treat with relative ease using the hydrostatic CRE balloons, there aren't really any clear guidelines for the management of sleeve gastrectomy stenosis specifically.
And we have another type of pneumatic endoscopic balloon which has emerged as a promising alternative to surgery. However, given the fact that sleeve gastrectomy stenosis is relatively rare, it occurs in 0.1% of surgeries, it has not been studied much, and there hasn't been comprehensive algorithm or guideline or even consensus about what balloon to use for what type of stenosis. Should we go to surgery straight or should we consider endoscopic therapies first? This is the reason why we embarked on our meta-analysis. We wanted to summarize all the available published data to this date to kind of come up with an algorithm and a plan how to approach these patients, which we see in tertiary medical centers not uncommonly.
So within our meta-analysis, we were able to find 18 studies that encompassed a total of 426 patients from all over the world that matched our inclusion and exclusion criteria. And among these studies, some of them used the more controlled radial expansion balloon, or the CRE, while others used the Rigiflex balloon. And other studies actually used both balloons, which actually provided a little bit more insight in our analysis later on. Overall, what we found was that the total success rate was 76%, with only 0.9% adverse event rate. And of the patients that failed to have success rates with the endoscopic balloon, 17% actually required salvage surgery.
Our secondary analysis included evaluation of the success of endoscopic balloon dilation depending on the location of the gastric sleeve stenosis. We separated those into proximal and distal. We found that, in fact, proximal balloon dilation was associated with higher success rate compared to distal stenosis. That may be due to several factors, one of them being easier access or difference in the type of stenosis, such as the length of stenosis and degree of axial deviation or torsion. There seems to be more of a twisting component in the more distal strictures located in the body of the stomach. We also looked at the length of stenosis, and we also looked at early versus late stenosis, which should be defined as at the 3 months mark after sleeve gastrectomy surgery. We found though that timing did not matter as much. However, one word of caution: we did not include patients with very early stenosis in the post-operative period within the first couple of weeks after surgery. These patients have to be treated carefully together with the surgical team, as they're at high risk of perforation and other complications. And before we go further into the algorithm approach to sleeve gastrectomy, I would like to mention a few words about the two balloons that we will discuss in our meta-analysis. Basically, the first one is the CRE balloon, which most gastroenterologists are familiar with. It comes in a variety of lengths and sizes, can be passed through the scope, and during dilation it exerts radial forces with inflation. The Rigiflex balloon, on the other hand, is also known as the achalasia balloon, is a fixed diameter, larger balloon which is guided by wire. It's a pneumatic balloon that does not pass through the endoscope, however, provides a greater radial force and with a larger balloon size.
So based on the meta-analysis that we performed, there are a few things that we actually suggest that can help guide future providers when it comes to endoscopic balloon dilation. So when it comes to the proximal stenoses, both the long and the short stenoses, which we along with the studies had defined the longer as greater than 3 centimeters and shorter as less than 3 centimeters. The proximal stenoses can be managed initially with the smaller CRE balloon with pretty good success. Actually, there are quite a few studies that actually demonstrated good success rates with the CRE balloon when it comes to proximal stenoses. Shorter distal stenoses, or less than 3 centimeters, can also be managed very similarly in the initial balloon. If any of these fail with the CRE balloon, you can always escalate to the larger Regiflex balloon as the next step in management. We do recommend, however, that for the longer or greater than 3 centimeter distal stenoses, these, as Dr. Popov had just mentioned before, have more of a torsional component to these stenoses. These would typically need a larger, more rigid Regiflex balloon in the beginning. And we also found that most of the successes that occurred in the study occurred within 3 attempts of the balloon dilations. And so should we find a stenosis that remains persistent despite 3 attempts, the best step in the next step of management would be to escalate to a larger balloon size. If the provider reaches a 40 millimeter, which is the maximum balloon size for the achalasia or the Regiflex balloon, if that fails, the next step of management would be a trial of stenting or any revisional surgery as the necessary second-line therapy.
And in summary, our takeaway points for you from this study are to consider endoscopic therapy as a first-line therapy. The overall success rate was 76% with endoscopic balloon dilation. If we add stents as another type of endoscopic therapy, that success rate goes up to higher than 80%. Of course, salvage surgery is always possible, but endoscopic therapy seems a viable option as a first choice. The choice of balloon, as we discussed, depends on the location and the length of the stenosis. I hope you will find these points helpful and find our study helpful to your practice. Thank you very much.
Thank you very much.